Good morning, everybody. Welcome to our webinar today. We have Hiva with us today to help answer questions. And so today we're going to go ahead and get started. We have an exciting new webinar for you all on medications. And, one of the things, and I'm sure Hiva can attest to this too, Hiva, if you're here, you can chime in, that one of the scariest things for me when I started prescribing or when I started becoming a nurse practitioner and changed my role was the prescription writing. That was just like very nerve-wracking for me. It was very stressful. I, wanted to kind of get on with it and do the right thing for these patients. But I just remember like handing out those first few scripts and my hands were just shaking, like, here's your Pepsid, here's your Tylenol, because I was so nervous about it. So maybe Eva can also attest to that as well. So yes, she's giving us a thumbs up. So, but you will get more comfortable as you go for sure. And just practicing and talking to your patients. The patients are very forgiving. You just want to educate them and talk to them and be, really watching over them and monitoring them as they're taking these medications. And, the thing is to the caveat that I'm going to give to all of you all today is the medications that we're going to talk about here are technically in the top 100 drugs list. All of them are. You guys have been given these probably for years to your patients, but you're probably just starting to prescribe them. And remember, the caveat that I'm going to give you here is that every patient you want to tailor. So just because on a guideline or a journal article that you read, it might be first line for 99.9% of people, but we definitely want to be doing custom care for our patients and making sure that they don't, have any contraindications to these medications, allergies to these medications. And so, just because I say it here today, I want this to be an interactive webinar that we can talk about what education pieces we're going to provide to our patients, what we're going to tell them when we're sending them out the door with these scripts. So just something, to keep in mind as you're going through that not every patient can take all these medications. And, as providers, we want to make sure that we're providing the correct thing for these people and really prioritizing, their safety when we're giving these medications. So let's go ahead and just dive right in. We have a lot to talk about today. So the first thing we're going to talk about is good old blood pressure pills. And I know you guys know about your blood pressure pills, and we give these all the time. These are some of the top prescribed medications that we give. And I just wanted to bring up some of the guidelines. So when we're talking about these medications, going back and referring back to the guidelines because we really want to do evidence-based medicine, right? And so this is our American Heart Association. Some of you guys know the JNC8, but our board's exams are really moving towards that American Heart Association and this guideline here. So that's why I picked that one to share with you today. But really and truly, I'm kind of, monitoring in here. And then when I start seeing that 140/90, that's when I'm really starting to see that this patient might need medication. Now, you guys can put in the chats if they are in the clinic today and their blood pressure is 140/90 or above, do I just automatically write them a prescription for blood pressure medication? I want you guys to put in the chats how that would technically work. What would you actually do for a patient and they had an elevated reading? So, so let's say that Heba's my patient today. Heba, I'm going to pick on you, and her blood pressure is 150/92. And maybe this is like the first or second time I'm seeing her, and she's just here for her well woman exam. She doesn't take any blood pressure medicines. What would be the correct course of action that I would do? So let's put that in the chats. I see some chats coming through. Absolutely. So we want to be taking more than one reading, right? So I'm probably going to talk to her about some lifestyle changes, watching sodium intake, getting that exercise in, and then probably going to be having her come back in 2 to 4 weeks with a little blood pressure log. She's checked her blood pressure, whether she has checked it at home with a cuff that she has, or some patients can't afford that $20, $30 to go get a cuff today at the Walmart. They are going to use, the pharmacy's blood pressure cuff enough, or have the fire department check it, just trying to find access for our patients. And so, can they get 2, 3, 4 readings in a week, and then, do that again and then bring that back to you? And if I could have a good 10 readings on a paper, that will really help me to trend it. And I see that at least 50% of those are above in that 140/90 range. I am going to consider medication. And, some of our first line medications that we can consider here based upon these guidelines are angiotensin converting enzyme inhibitors. Now, you guys remember that that renin angiotensin system that helps to control the blood pressure. It also helps to control some of our electrolyte balances, cardiovascular health, these types of things. That ACE2 is the one that really, in that cascade, is the one that really helps to constrict those vessels, right? So angiotensin converting enzyme inhibitors is going to help ACE1 not to convert to ACE2. These are given very, very commonly. Some of our gold standard of care that we're given in primary care are these ACE inhibitors. Now, patients who are pregnant, they are not going to be able to take an ACE inhibitor. And in fact, if you see one of your patients, maybe was started on an ACE inhibitor in kind of a young age, and then they end up, they're trying to conceive, or, they come in and they're pregnant or whatever, we're going to want to change them off of that medication. And so the other thing that you can see is angioedema is a common thing that we can sometimes get with these ACE inhibitors, especially the African American population. So we really want to be watching there. These ACE inhibitors can cause a dry cough, often annoying for patients, but it's pretty benign. But if I see that they're starting to have problems, like they're getting that itching, they're getting those swollen lips or tongue, they're not being able to breathe as well, they have a dry cough, just anything annoying or dangerous, or they're pregnant or wanting to become pregnant, that is going to automatically disqualify them for an ACE inhibitor, probably going to move to an ARB, unless the pregnancy thing, we'll talk about that in a minute, we'll circle around. But the ARBs are going to be our next line. They also are right up there with the ACE inhibitors. They work a little bit differently. Instead of preventing the conversion, they just simply block the ACE2 receptors. They often end in sartan, so like losartan's one that you'll see a lot of your patients on. And then if these patients are wanting to become pregnant, I want you guys to put in the chats our safe pregnancy medications for blood pressure. So you all can go ahead and put that in the chats, and we are going to go over that mnemonic here just in a minute before we change the page, okay? Calcium channel blockers, here's a hint. One of the medications that's safe for pregnancy is a calcium channel blocker, okay? And these just inhibit the movement of calcium into cardiac cells. They often end in pine. There's a few like verapamil that might be on there. But the amlodipine, so I put the pine in there for the ending. And then beta blockers, another hint for you guys for those pregnancy safe ones is one of the beta blockers that we use is safe in pregnancy. These end in LOL. They block the release of stress hormones, again, often used in pregnancy, often used in nursing school as well, because they block those stress hormones. Those students that get a lot of test anxiety, sometimes they're taking like propranolol, something like that. It's a beta blocker. But the main thing with the beta blockers is that we don't want to stop those abruptly. So that's one that I just always, encourage my patients that if we're doing a beta blocker, don't stop that abruptly without talking to me. That can cause a lot of problems. And then the other thing is with asthma, it's not great. And with diabetes, it's not great because sometimes beta blockers can cause that bronchoconstriction. And I remember the B for the B, beta blocker, bronchoconstriction. And then also the other thing is that it can cause blood sugars to have some issues as well. So it's not my first line in that population, but again, they have their place. If patients have high heart rates and things, that could be a good go-to. And then your thiazide diuretics is going to increase the release of sodium and water in the urine and basically make them urinate. And, all these patients hate these diuretics. Why? Because that's their water pill and they're always in the bathroom. So talking to them about, warning them that, yes, this is going to make you urinate. And that is part of how the medication works. So what do we have here? I'm going to look at the chats. Absolutely. We have LMN, labetalol, nifedipine, and methyl dopa. And those are going to be our safe pregnancy blood pressure medications. And again, I would encourage you to be working with, GYN, or if they have a cardiologist or whatever, if your patient is hypertensive and pregnant. That should not just be a primary care management alone. That should be a referral out so that we can make sure that they're taken care of and they don't have some sort of other complication in pregnancy. Another pop quiz for you guys that I have before we move on is if you have say that they're not super responsive to the first line, like say I started, HEVA, we'll say I started HEVA on lisinopril, 4 weeks later, because I see that her blood pressure wasn't just white coat syndrome. She wasn't just stressed when she came in. She actually is having some high blood pressures and she's not responding to that. What could I do without, we'll say, adding another medication? That's kind of, we are adding another medication, but how does that work? Do you guys remember? So for example, I'll say lisinopril dash HCTZ. That's like an example. So how did some of these pills come that we can kind of get some bang for our buck? They're only taking one pill, but we're getting bang for our buck. That's by using combo medications, right? So some of these medications in this class can be used together. And again, that's still kind of that first line treatment, but if they need a little extra support, you can add on a combo medication. All right, we're going to go on to hyperlipidemia now. Let's talk about our screenings and our ASCVD calculator. So you guys know that we're basically screening now at different cycles of the lifespan. Once they get about 70 to 75 years old, we're kind of the starting of the statins is kind of going to be, really what are the risk factors and things. But, in that 35, 40 years old up to 75 years old would be when we would really look to be starting a statin with these patients. And remember, we're using the calculators, right? And once you put in things like their smoking history, whether or not they're on antihypertensives, whether or not they're diabetic, it's going to spit out a percentage for you. And you can share that with your patients and you can really explain what that means to them. And as you're educating them and talking with them, of course, we're talking about lifestyle changes with them. But if you're starting to see over here in that borderline move into intermediate risk, that is where you're going to want to start looking at starting a statin. And remember, for our statins, the good news about those is there's only about 8 of them. And depending on how you dose that depends upon a low, moderate, or high intensity. So the statins to me are a pretty easy drug class to remember because basically just depending on how I need to use it, if they've had a cardiac event or if they're above 20%, they're going to be on a high intensity statin, right? But most of your patients are probably going to be hanging out in this moderate intensity statin. But again, just thinking and looking at this to where you can adjust the dose to go from low to moderate or moderate to high. And if you kind of know where your dosing's at, that's going to be a really easy way for you to remember this for your boards and in practice. All right, just as a reminder here, whenever we're starting a medication, it's ideal to give these patients something to look for when they are starting the medication and we're not trying to scare them. And I always just tell them like, this is very, very rare, but I always just have to tell you that, these are some things that I want you to be looking out for you to let me know. And of course, with statins, we can have the rhabdomyolysis. This is an emergency. They start having that severe muscle pain. I'm not talking a little leg cramp at night. Okay. I'm talking severe muscle pain, dark brown urine. They're going to be going to the emergency room. Drug-induced hepatitis also may be going to the emergency room, but we can start by ordering a CMP. But these are just 2 very rare but serious complications of your statins. Of course, the most common one that you'll hear of is like some muscle aches, simple things like that. But again, these are like our severe concerns that we have with the statins. All right, let's talk about diabetes for a minute. Again, as I said at the beginning, this is not a lecture on a certain anything. So we're just going through the very first line agents here. So one of the things that I remember for diabetes is, where do I want to start a medication? So first of all, if they're in that pre-diabetic range and they've just had maybe 1 or 2 A1Cs hanging out in here, I can kind of trend it And if it's going down, maybe we stick with lifestyle changes. Maybe they were a 6.3 and now they are a 5.7. Okay, I might let you ride. But if you've gone from 6.4 or 6.2, whatever, to 3 to 6 months later, you're maybe at a 7, right? We might want to consider starting you on some diabetes medications, in addition to the lifestyle changes. And so some of the things that we will start looking at is MET1-2. That's my little mnemonic for remembering my first line diabetes medications. So the first thing I'm going to start with is metformin. So that's where I get met from. And this one here is going to be the only Baguanide that's going to be used in the United States. This is the first line type 2 diabetes medication. Remember, type 1s have to have insulin, right? So we're specifically talking about type 2 here. This one here most commonly causes those GI symptoms that those patients don't like. So we definitely want to look at maybe starting them low and going really slow. Maybe they start with 500 milligrams at their largest meal of the day, work their way up, right? And I have that here for you, gradually increase. There is an extended release of this, so that also can help. But then also I want you to think about and tell me on here on the contraindications, renal impairment. There's a GFR cutoff for metformin. Do you guys know it? Can y'all put it in the chats? All right. GLP-1. So I said MET1-2, right? For our first line type 2 diabetes treatments. Okay. So GLP-1s, those are all in the rage, all in the news right now. Of course, these Ozempic and Wegovy, you guys know about that. For sure, a lot of our patients are asking for that. Just a little pearl here for you. Ozempic is the one that's FDA approved for diabetes. It does have a weight loss side effect, if you will. And so it is good to give them some bang for their buck. But Wegovy is the one that is for the obesity. So it's still semaglutide, but they're in two different brand names. And that's the difference between these two. So I'm giving Wegovy for obesity, Ozempic for those who may also have obesity, but for our type 2 diabetics. These are going to be those once a week shots. We, of course, want to check for any history of thyroid or pancreatic cancers in our patients. We want to remind them to go once weekly on the same day. And of course, these have a black box warning. What are our black box warnings for our GLP-1s? Can you guys put that in the chats for me? And here is a little hint for you down here. It causes delayed gastric emptying. So what could that possibly lead to with why we would have a black box warning for something like a Ozempic or any of these GLP-1s, but Ozempic or one we're given a lot? It's going to be small bowel obstruction, right? So again, these work by slowing down the GI tract. So I'll tell my patients, if they're starting on this, 50% of what you normally eat will start with at your meal. You're going to increase fiber and water intake, and you're going to call us back if there is no BM in 3 days. And they can take Miralax to help with that as well. And again, we want to start them low and slow. I'll start them at 0.25 milligrams for the first month. See them back. How'd you do? Did you have any problems? Nope. Doing well. Okay. 0.5 for the next month, and check in on them again. And then we might go up and look at like 1 milligram. But again, these are going to be titrated really low, really slow, because these do have a black box warning, regardless of what celebrities in Hollywood has taken this. So we really want to be careful when we're prescribing these. Okay, I said MET1-2, didn't I? So the other option instead of doing a GLP-1 is looking at an SGLT2. These here are listed here. One of the ones we give a lot for our heart patients, even if they're not diabetic, because it helps, is Farxiga. Jardiance is another one. And these are going to be given for those who either can't tolerate the GLP-1s or maybe they don't want to take a shot. Although semaglutide did get put in Rybelsus, which is a oral medication. But this one here can often cause like yeast infections and things just for its mechanism of action, because it does help to promote, they're going to be urinating a lot of sugar. If you check a UA on these patients, the first couple of times I did it, I didn't realize like how I kind of had to go back and look at the mechanism of action, because I'm like, why do these patients have so much glucose in their urine? Well, that's the mechanism of action that they're on. So, or the mechanism of action. So you're going to see that urinalysis have glucose in it if you start them on this medication, most likely. But again, a lot of sugar in the urine can cause things like UTIs, yeast infection, and dehydration. So again, just be watching for that, warning for that, letting them know. And again, if they're having like a lot of yeast infections or UTIs, may need to consider changing it to a different something. But again, we're sticking with first line clinical pearls on our first line things that we're given to, a lot of people. All right, let's talk about hypothyroidism for just a minute. That is going to be treated with your levothyroxine or your Synthroid most of the time. And this one here is going to be, you can have primary or secondary. Of course, Hashimoto's is pretty much one of the top causes for hypothyroidism. But as you can see here, there's some other indications that can cause it. Oftentimes, these patients will remember, everything is kind of slowed down. So slow growth or anxiety and depression, dry skin, maybe some hair loss, weight gain, constipation, fatigue. So things are kind of slowed down here. And then oftentimes you'll have some clinical features. And then remember that inverse relationship with how the TSH and the T4, T3 work. So your TSH is going to be elevated. And I really took a while for me to get that through my head. Elevated TSH is hypothyroidism, whereas the lower one, we were thinking about hyper, right? But the thing here is the low T4, T3, because levothyroxine is essentially what? T4, right? And so something that we want to check for. If you want to check a TPO on a patient, that's specifically looking for Hashimoto's, but you can do that. But the treatment here initially is going to be, like I said, levothyroxine, Synthroid. It's going to be on that, within the top 10 medications that we use in primary care. This is going to be age and weight based. You're going to adjust your dose every 4 to 8 weeks with lab work, okay? Remember, it has an inverse relationship. So if the TSH is high, the T4 is going to probably be low. And so as we're trying to titrate them and adjust them, don't forget about that. And get your labs and your medication titration confused. And then, of course, you're going to counsel patient. You want to give this on an empty stomach, 30 to 60 minutes prior to breakfast or a little bit after dinner by a few hours. And you don't want to take it with iron, calcium, and acids or PPIs because it might just inhibit some of the absorption. Not necessarily going to hurt them, but it may not be as effective. It may decrease its effectiveness. And then just an FYI, if your patient becomes pregnant or is trying to conceive, these patients may have a higher dose requirement of this medication. Again, are going to be working with OBGYN as well so that we can make sure that they're on a therapeutic dose. They might be on 75 regularly, but then if they become pregnant, we may have to go up on that. So again, constant lab work and monitoring, especially in pregnancy. All right, let's talk about asthma for just a minute. This is an obstructive pulmonary disease that begins with a trigger, such as an allergen, virus, or even exercise that causes airway inflammation, leading to increased mucus production, swelling of the bronchial tissues, and muscle constriction, right? Who can put in the chats how you diagnose asthma, right? Patient comes in, maybe they've just had a really bad sick season. They've been really ill. Maybe they have exercise-induced asthma. Maybe they've moved to a new area and some sort of allergen has just really triggered them and got them really flared up. If we are thinking about diagnosing a patient with asthma, one of the first things we are going to try to do is get that spirometry testing, right? Absolutely. That's going to be our gold standard test. Remember that FEV1, FEV is going to be that ratio at 80% when we have the spirometry testing. Oftentimes this is done in like a pulmonologist's office. Some of the places will have it for outpatient, but again, checking your ratio, 80% here. And then this is going to be your guidelines for care. Now, remember, there's also an asthma control score that you can kind of assess your patients with. And if their score, I think, is under a 19, then they may not be well controlled. And essentially, it's asking how much albuterol that this patient is taking and having to use. So remember, the guidelines changed about if you have been to school longer than 3 to 5 years ago, the guidelines changed around 2020. And instead of just taking a lot of short-acting things like albuterol, we're really trying to move to more of an inhaled corticosteroid model. And so the GINA guidelines, which are the most common ones, I would say, the National Heart, Lung, and Blood Association has some guidelines, and albuterol can still be first line if that patient just doesn't want to give up their albuterol, or if it's just very, very mild. Everybody should have a little albuterol on hand if they have asthma or COPD. But we're trying to go more towards this model of using inhaled corticosteroids, and we can use it as needed. And then you're going to just continue to titrate up depending on what is going on with your patient. Now, as you start getting down in here to around step 4, because they're having symptoms most days, they're waking with asthma once a week or more, just low lung function on that spirometry testing, I want you to go ahead and start thinking about sending these patients down here, maybe a 3 that's having a lot of exacerbations, or a 4, that's when they need to really start looking at maybe talking to pulmonology. And we can just continue to go down this line and, give them the inhalers. And then we also want to consider smart therapy, which again, that was part of the update, using the same inhaler for rescue and maintenance. So you can see over here, they might be using the PRN ICS because they're kind of just having it intermittently, but maybe they're sick. We're coming up on sick season, and they may have to take it daily, right? So, so just seeing here that you're kind of getting more bang for your buck instead of them having to always go between albuterol and the inhaled corticosteroid. And one thing I always tell my patients too is, if you're in the back of an ambulance and you've had some sort of really bad asthma attack, or maybe you have had an allergic reaction to something that you or wasn't expecting, you're in the back of an ambulance, or you're in an emergency room somewhere, you're going to want to make sure that albuterol is the most effective for you. And if you start getting to the point where you're taking a lot of albuterol all the time, you're not well controlled, A, but B, it's going to probably be a lot less effective for you in an emergency situation. And so we want them using albuterol 2 times a week or less, just in general. And if they are using albuterol more than 2 times a week, probably not well controlled, probably need to step up in their therapy. And again, maybe get them to pulmonology, at least for that spirometry testing, and kind of taking a stab at it and get back to the drawing board. So just a little caveat there that I try to talk to my patients about with albuterol. All right, so we talked about smart therapy. All right, let's talk about depression a little bit. So again, we're going to go through the first line, treatment for depression and anxiety. I have several things listed here for y'all. Of course, SSRIs, I would say, are going to be some of the most prescribed medications, and that's the one we're really going to focus on today. But of course, we're going to screen our patients with that PHQ-9. We can do a history and physical on the patient. We're, of course, going to want to rule out organic causes. So things like, is their thyroid off, or, are their electrolytes off, or is something that could be causing their fatigue or their low libido, or do they have sleep apnea? Maybe they're not sleeping well, and not sleeping well can contribute to their moods. So, vitamin D deficiency, vitamin B deficiency, their energy is just low. So just really trying to rule things out before we just stamp depression or anxiety on it. Of course, we have non-pharmacological treatments, which we're not focusing on today, but still very important. Talking to my patients about, we don't just take a pill. We don't just take Zoloft for depression. We are playing an active role in getting better. We're talking to a therapist. We are working on our relationships. We're doing our exercise. We're getting our sleep. And we're really just wanting to set them up with the tools so that they can go home and do these things to help, stab it from multiple angles so that they can get the best outcome for their treatment of really anything, but especially these mental health disorders. Same thing for anxiety. You're going to use the GAD-7, want to rule out any other origins for anxiety. And of course, just sensitively asking these open-ended questions. Of course, lots of different options for treatment, but our SSRIs are going to be at our very top. So that's what we're going to focus on. So when we're prescribing our SSRIs, We need to talk to them about how these work by blocking and inhibiting the reuptake of serotonin. They keep the serotonin available in the brain. I tell them it goes from their gut where it's made and brings it up to their brain where it belongs. It improves their mood. And y'all tell me, I'm going to ask y'all to put it in the chats because you have to know this. How quickly are they effective? So first of all, I've got a little cheat for you down here. Are they effective the next day or the next week or the next month? When are they the most effective? And then also, there's a black box warning for SSRIs. Can you guys tell me what the black box warning is, and specifically to which age group is going to be our most concern? So I'll pause for just a minute and ask y'all, what is the black box warning for your SSRIs? And then how long does it take for them to work? So y'all put that in the chats. Y'all are doing great today. Y'all have been a really good group. So absolutely. So you guys know that this can take 4 to 6 weeks to reach effectiveness, but they may start to feel better after about 7 to 14 days. I usually say 14 and kind of err on the side of caution. Don't want them to, ditch the medicine too soon. And then, of course, our black box warning is going to be suicidal ideations, specifically in our younger people, like our teenagers, early 20s. And then side effects of SSRIs, you guys know, weight gain, decreased libido, GI upset. Of course, here's our black box warning. Of course, contraindications. We're always worried about serotonin syndrome whenever we're talking about these with our patients. And so we want to give them some of the warning signs. That'll be on my next slide. So we'll look at that there. And then I've just got them listed for you on what some of these medications are. All righty, so let's talk about serotonin syndrome here. So, of course, excess serotonin will cause a buildup of that, and you don't want it to be too high. And so, of course, whenever we use some of these medications, like amitriptyline might be on there, like a migraine treatments, antidepressants. So that's why we don't give SSRIs together. If your patient's taking St. John wort, I would advise them to stop that before they start their SSRI. And then, of course, here's some of our symptoms that we want to talk to our patients about. And then, of course, this is going to be a medical emergency, and you're going to remove that offending agent. So again, if they start having any of these symptoms, we are going to tell them, bypass my office and go straight to the emergency room if they start to experience any of these things. All right, let's talk about GERD, gastroesophageal reflux. There's oftentimes no typical physical findings that I can find with, my stethoscope. Patient history may complain of like heartburn, acid, feeling, belching, heaviness on their chest. Of course, we want to rule out anything cardiac if they're complaining in that area. Wanting to see if they're having a lot of spicy or acidic or fatty foods. And again, some of those red flag symptoms I have listed for you, difficulty or painful swallowing, early satiety, and we're going to go ahead and refer those patients out immediately for an endoscopy. And of course, our first line treatments for these patients is going to be lifestyle changes. Are they going to get tacos every day, or, drinking a lot of alcohol? We want to help them to reduce that. And then our H2 blockers are going to be one of our first lines. So that's going to be like your Pepcid is one that we give a lot, and they are going to block the histamine on the H2 receptors on the stomach, reducing acid. Pop quiz here for you guys. When else can we use an H2 blocker? Y'all can put that in the chats. When else can we use an H2 blocker? What else could it be used for? And then PPIs is going to be your gold standard of care. If I want you to think about a wedding cake, and at the very top of the wedding cake in a little gold shiny paper is a PPI, and that is going to be your proton pump inhibitor. It's going to be one of your gold standards of care for GERD. We can use this in severe cases. People who already have comorbidities, like maybe they have Barrett's esophagus or something like that, and they're having, heartburn, we're going to give them a PPI because we don't want those esophageal cell changes, right, to go ahead and move them on to cancer. And then the other thing is that if they're elderly, we might start them on a PPI as well. because again, elderly people can have things like GI bleeds and stuff, and so may go straight to a PPI. So again, just depending on how bad their symptoms are. And absolutely right, you guys, H2 blockers can be used to help with like allergies. So like allergies, itching, things like that. So sometimes we'll give these medications because again, it's a histamine blocker, right? All right, so let's take a look and list and talk about estrogens. So I have put a caution sign up here for you guys. This is one that it has a lot of usages, and we have to be careful because what can happen with unchallenged estrogen in females specifically who have not had, who still have an intact uterus. You guys can put that in the chat. So when we're prescribing any type of estrogen therapy, we really want to be careful. We really want to be paying attention. So, of course, at the very top of our list, we have contraception. Now, who can put and tell me why we would not just give plain old estrogen for contraception? Why are there combination pills made? And what does a combination pill have in it? So, y'all can put that in the chats. And then, of course, hormone replacement therapy. Maybe they're having some sort of menopausal symptoms. We do have a new medication on the market called Veoza. So if they're not a good candidate for hormone replacement therapy with estradiol or whatever, we can start looking at trying like Veoza. Also low doses of an SSRI, like a 25 milligrams dose of Zoloft, something like that can help with some of those menopausal symptoms like hot flashes. Of course, osteoporosis, they can be helpful, but they're not really recommended solely for prevention. So, use that one. It really doesn't, it's not going to hurt them, but we're not going to prescribe it because the risks outweigh the benefits for that. And then, of course, our atrophic vaginitis, where they have like vaginal dryness, things like that. Really, ideally, we are going to give this for topical use. They're going to take it intravaginally, and that is much better used long term than a systemic pill form. And so you can give some of these vaginal creams, and these are actually safer and I'll say just as effective for like vaginal dryness or urinary symptoms due to atrophic vaginitis. We can give this. It does have some systemic absorption, but not nearly as much as if they're taking it in pill form. And then, of course, pain during intercourse due to atrophy, we can give it as well. And then back to hormone replacement therapy and contraception. You guys got that right. Great job. We're going to give a combination pill with progesterone to decrease the possibility of things like endometrial hyperplasia, which can then increase risk of cancer, like uterine cancer. So, and you guys got that right. I've got it right here. Their risk factors for endometrial cancer is going to be increased with unopposed estrogen, and so it's reduced with combination. So that's why we're going to give progesterone with it. Also, cervical cancers, most studies showed no increased risk. Ovarian cancer, it can be protective, but the thing is that breast cancer can be increased with estrogen use, especially estrogen use only. So we want to, really be looking at the risk versus the benefits. Is there something else that these patients can take? And recent guidelines also have talked about how once women are over the age of 65 or 10 years after menopause, whichever one comes first, we're really trying to get them off of the estrogen systemically. So that's just another thing to kind of keep in mind. Why is a 72-year-old taking estradiol? I'm probably going to be really asking that question. And, if they're taking it for hot flashes and they were given it 20 years ago, well, can we do a trial without it and see how they do? So that's one thing that I will definitely, be counseling my patients on. All right. We're going to talk about antibiotics, and then I have some questions for you guys to practice what all you've learned today. So, of course, we're just going to go through the main antibiotics, and then I have a picture to show you. So, penicillins, of course, this one here is used for gram-positive cocci, very broad spectrum antibiotic. We have penicillin G, we have penicillin VK. You guys tell me, what is the most common use of penicillin, specifically penicillin G, today? Because we have a lot of resistance to penicillins, right? right? So of course, penicillin is going to be that mother drug, if you will, of those, cephalosporins, things like that. But, we have good old penicillin. And you guys remember, what do we use just straight penicillin for today? Do y'all remember? I'm not talking about amoxicillin. I'm talking about penicillin G. Putting it right here. Syphilis. We use penicillin, just plain penicillin for syphilis. That's really about the only thing due to the resistance. Okay. It is pregnancy safe, but penicillin's, amoxicillin, part of that. And those are widely used. All right, our sulfa drugs here. Remember, we have Stevens-Johnson syndrome is a possibility with those. A lot of patients are allergic to these. I will say that. So check your allergies. These inhibit bacterial enzyme activity, but they often are combo pills. So things like Bactrim right here is a combo, and you'll see the sulfa drug. Common uses, again, first line, sometimes for like UTIs, acne, or skin infections, but these are not generally used in pregnancy. Also, if your patient has low renal function, you want to watch these sulfa drugs as well, because like Bactrim isn't good for people with like a lot of like kidney disease or damage. Tetracyclines, caution is teeth staining in under 8 years old. You guys remember that this one is going to be used in Lyme disease. Recently, they've been looking at the guidelines. We used to only give amoxicillin to those patients that were under the age of 8 with Lyme's. Everybody got it for Rocky Mountains spotted fever, but now they're kind of looking at risk versus benefit. So you may see some guideline changes coming up there. Of course, doxycycline, like for an example, is really great for like skin, acne, things like that. So something that you can use, and these are not generally used in pregnancy, but one thing I like about doxycycline or these tetracyclines is that, specifically doxy, is that it's good, like it's just a good overall broad spectrum antibiotic, but then also it doesn't really have a renal adjustment on there. So that's another one that we can kind of use for people who can be like compromised with their kidneys. All right, cephalosporins, that's that cousin of your amoxicillin family, and they, of course, are going to inhibit the wall of gram-positive and gram-negative bacteria. These are broad spectrums, and I would say that this is probably one of the most common drug classes of antibiotics that we give. These are great just all the way for things like skin infections, bone infections, upper respiratory infections. Of course, some of your STIs are on there. They can cover MRSA. They're good for ear infections even, like if the patient's not responsive to amoxicillin, or maybe they've had 2 or 3 ear infections and the amoxicillin is just not taking care of it. You have different generations, so just FYI here. But of course, Keflex is something that we give, Norcephin, you guys know. These are things that we're given all the time in primary care. All right, macrolides. You guys know those. Some of the ones is like Zithromax that you're going to be, erythromycin that you're going to be familiar with. If your patient's on a blood thinner, be careful. These are really good for soft tissue infections or respiratory infections, reproductive organ infections, and also these are pregnancy safe. They are a good alternative to things like penicillins and cephalosporins. So again, lots of Z-Paks, lots of erythromycin that we hand out throughout the year. All right, fluoroquinolones. This is one that you definitely want to reserve use for. This is one that I really take caution in prescribing. We really want to be good stewards of these. These get into a little bit higher, I would call them bigger gun antibiotics. Not the biggest guns, but bigger guns. And these are not really used in pregnancy. There are renal adjustments that we can make. So like maybe once every other day or once every 3 days, they might be taking the Levaquin or whatever. But again, if your patient is got like a lot of comorbidities and UTI or respiratory infection, and it's not responding to some of the other things, or they can't take some of the other things, you can use this. But again, I really try to reserve fluoroquinolones for those cases that just are a little bit tougher and can't be cracked. All right. This is just a picture that I made for you guys. This is something that I kind of just literally had in my notes from NP school, and I just wrote it down. You can go look up the Antibiotic Man, and you can see there's all kinds of versions of this. But this is just like the first line for some of these things, and it just kind of gets your mind around. We use different antibiotics for different things. And I would say that for me, prescribing antibiotics is we want to, have they been sick 5 to 7 days? Antibiotic stewardship, we're really looking at that. Have we tested them for strep, and have we tested them for viral things like a respiratory panel before we're just throwing antibiotics at people? Of course, working in the urgent care, everybody just wants an antibiotic shot and a steroid. They're ready to go home. And we really have to educate our patients on, antibiotic stewardship and what's appropriate. And of course, reserving those big gun antibiotics for the big gun things, and just really working with our patients to get the word out of what is the best course of action with antibiotics. There's lots of resources. There's Hippocrates, there's UpToDate that can kind of give you some ideas on what antibiotics you might want to use for what. Like I said, this is just literally just something I had in my notes that I kind of just gave you a down and dirty, just for some examples to kind of sum up those other slides that we went through. But this is something that you might, like I said, really look up and use as a reference. But again, tailoring it to your patients. And of course, we didn't talk about the community acquired pneumonia. That's what CAP stands for here. If they have a lot of comorbidities, like I said, can consider monotherapy for fluoroquinolone, but you can see you have all these other options up here. Same thing for your UTIs. So really just paying attention and making sure we're reserving these antibiotics for the appropriate time and the appropriate patients, because we don't want to create resistance. Now, this is just something that I have created for you guys. This is something that I actually saw as a student, and it's this little circle here on the GINA guidelines. If you look at the GINA guidelines for asthma, they have a picture that's very similar to this. And I thought, instead of just for asthma therapy, this really goes for everything we prescribe, right? Because we are going to prescribe the medication. We're going to check all these boxes and probably more. Then we're going to bring them back in. If I'm starting them on something new, I'm going to bring them back in anywhere from 2 to 6 weeks, depending on what I'm prescribing, and give them the appropriate lab work. If I've started a blood pressure or a statin medication, I want to get a CMP. If I've started a thyroid medication, I'm going to get TSH, T3, T4, whatever it be. And then I want to assess them, and then I want to titrate the medication. And so I'm always trying to give my patients the least most effective dose of whatever medication I'm giving them. So, I'm going to prescribe it, educate them. We're going to reassess them in, like I said, that we'll just say 1 month for rule of thumb, and see how they're doing with it. Does the medication need to go up or down? And then we're going to bring them back in at that 3 to 6 months for the refill to prescribe. We're going to also do another assessment at that time, whether it's, labs and a physical exam, talking to them, getting a good history of how the medication is going. And then again, titrate. Can I bring it down? So like, for example, can I bring them down from a PPI to an H2 blocker, right? And remember, these PPIs, they're good for like short-term use. That's one thing that I didn't mention earlier. So, after 12 weeks of a PPI, are we bringing them back in and reassessing how their GERD symptoms are doing? And if they can be weaned down to Pepcid, and if they're failing the Pepcid trial, then they need to go to GI, because again, that is, like I said, if you think about the pedestal, it's at the very top. So always just kind of reassessing and checking in on your patients and giving them the least most effective dose is going to serve you well. The other thing is just some rules of thumb. This is just literally the Brittany Long pearls that I wrote down for y'all. Know your patients and their labs. So do they have comorbidities like we talked about with the beta blockers, and they're diabetic or they have really severe asthma? They may not be a good candidate for a beta blocker. Creatinine clearance. There is a Cock-Off-Groff calculation that you all can look at on MD Calculator. And if you put in their weight, you put in what their creatinine was, and it tells you their creatinine clearance. Many medications have to be adjusted based upon creatinine clearance. Also, elderly patients are unique. Pregnancy patients are unique. So these patients that are elderly, looking at polypharmacy, if they are 85 years old, they may not need estradiol anymore. So, like just checking and seeing, is there something that we can discontinue or do a trial off of, or even if they've been on it 30 years, well, I don't even remember why I'm taking that. Okay, well, let's go back and do some digging. And if some sort of specialist puts you on it 25 years ago, maybe we can, titrate it down or send you back to the specialist to talk about, do you need to continue it, whatever it be. So trying to decrease risk of polypharmacy in our elderly patients. I don't want you to be taking medicine to combat side effects of another medicine. And then Beers criteria, thinking about those patients that are over the age of 65 and what is safe for them. And then also barriers to care. Um, does this patient have an affordability issue, right? Because Walmart, Publix, several of the places will have like a $4 list or a $10 list. So, you might want to prescribe a big fancy medication, but the patient can't afford it. And so something is going to be better than nothing. Can they get it over the counter, whatever it be? Also, compliance regimen. Maybe they are forgetting to take their medication. Maybe they, don't have the resources to go out and get the medication. Maybe they need to go on home mail order because they have nobody to bring them to go get their refills. Or maybe they need a 3-month script versus a 1-month script, whatever it be. But think about your barriers to care and your accessibility. And then also risk versus benefits. You want to consider and discuss all of those with the patients. Sometimes we will take a risk for a benefit. So, the medication, it'll, run it through your EHR, run it through your interaction checker, and it'll say avoid, or it'll say, not recommended with this one or whatever. But sometimes, if the patient is really sick or whatever, we may have to really weigh those risks versus benefits. And we want to consider that, and we want to discuss that. And we also want to document that. Why did we pick that medication? It was risky. This is why. I've talked to my patient about this. I've educated them about that. So it can get a little scary, hairy at times. And then also checking allergens, checking pregnancy status. And, did you ask, I don't care what the nurse wrote in the chart. I don't care what the MA put at the front. I don't care what the receptionist wrote down. I, as the provider, am going to ask what are their allergies and then offer them a pregnancy test if that is indicated, if they are of childbearing age and they're not sure, or they just want to do it or whatever. I will offer that to my patients. So again, just some rules of thumb for you. I'm sure we could sit here all day and probably add more on those patient safety things. Y'all know your rights of medication from RN school, but this is something that you just kind of want to think about when you're prescribing. All right, let's practice some questions. So before we get into our questions here in a minute, I'm just going to do a little pause. We have a 3-day live review coming up with myself, and Hiva will be there, and we have some of the other instructors that y'all know, and we really want to invite you to that. Now, how do you get to come to that is you purchase our SurePass package, and that is going to let you get that QBank access of 1,600 plus questions. We have just finished working on that. The questions are really good. They all have very thorough rationales as to why they were right and also why they weren't right. And then also there's on-demand videos. Hiva is one of our instructors in that. They all look great. They are in bite-sized videos. You can take these on the go. You can download them. You can listen to them in, car line pickup or whatever you're doing, and really just supplement some of your, texts and bring it down to the down and dirty for you. In-depth topic coverage that we're even going to be able to go more in depth on than the live review. And then, of course, the live review coming up is going to be here just in a couple of weeks. You can still get in on this. I've got your QR code for you. And again, that's going to be 3 days, Friday, half a day, Saturday and Sunday. And you all will get to come and really just get to sit down with us and talk about these topics. We go system by system. It's a lot of information, and it's also, this SurePass has the pass rate guarantee. So if you have any questions, we want you to email us here, nursepractitioner@archerreview.com. But regardless of if you buy anything today, I get it. You're a student and sometimes you can't buy it today. We want you to connect with us on social media. We are giving away a giveaway tomorrow. We have another giveaway coming up later this month. We also have the free trial of the Q Bank for 7 days. So if you have a big test coming up or your boards are coming up, look into that. Also, we want to connect with you on social media. We give free questions of the day. We put information on there, and sometimes we just put something funny just to encourage or uplift you or make you laugh, because we get it. FNP school is hard, and being an FNP can be hard sometimes too. And so we want to just be a good community of support. So we have a lot of different things for you here that are absolutely free, that we would love to connect with you, engage with you, just like this free webinar today. We have more webinars coming up later on this week and next week. So connect with us, just join our community. It's a really great, uplifting, supportive community that I really wish I had been part of when I was in FNP school.
And Brittany,
All right, let's go ahead.
those links in the chat for everyone. So I put in
Perfect.
links for our Archer homepage for the NP product. Also, the SurePass you guys can check out to join the awesome 3-day live review next week that Brittany talked about. And I also put the link to our Facebook group on there too. So check us out. And yeah, the giveaways are amazing. So don't miss out.
Yeah, we gave away a SurePass last month during one of my webinars, and we're going to be giving away something else tomorrow during Morgan's. I think Kiva is what she said. So be sure to check out our social media pages. Those webinars are free to attend, and you can get your name in there, and you might win something that's really helpful for you. So I would really encourage you to check that out. The other thing that I did not mention is we still are offering tutoring and mentoring. And if you would like to sit down one-on-one, whether you just have a big test coming up, and I'm not talking about the boards, you're just stressed about your cardiology test coming up in school, or you are getting ready for the boards, whatever it be, we would be happy to sit down, talk with you, and spend some time together, just one-on-one, going through, whatever you'd like to go through. So that's something that you can also take advantage of. Maybe Heba will put that link in the chats for you as well.
Absolutely.
All right. So without further ado, let's go through these couple of practice questions that I have for you guys. Again, this is an antibiotic question. Miss Hiller, 82 years old, was seen in the ER last weekend for cellulitis on the right lower extremity. She was placed on clindamycin and told to follow up in primary care within 3 days. She states she's taken the antibiotic exactly as prescribed, but has not improved at all. Wonders if she needs more antibiotics. The nurse practitioner decides which agent would be best to proceed with. So you guys take it at your best stab. This is actually one that we did not talk about today. This is moving to a bigger gun antibiotic. So there's your hint. But this is one that, I want y'all to know for boards for sure. All right. And very good. That's vancomycin. So we're going to move from one up to a more stronger antibiotic for her. All right, so this one here, Miss Steele comes to your primary care clinic complaining of urinary frequency, urgency, and dysuria times 3 days. She's afebrile, denies flank pains, and states that she found out she's pregnant 2 weeks ago and will see her OB next week. Her urine dipstick was positive for nitrites, and the nurse practitioner decides to treat her for a UTI while awaiting the culture. The nurse practitioner chooses which of the following to treat her suspected UTI. You guys are already lighting up the chats. Absolutely. That's right. Amoxicillin. You guys know that. Of course, macrobid is going to be your first line, but if they're pregnant, it's going to be amoxicillin. Of course, our Cipro is going to be for our more complex UTIs, because we're going to reserve our fluoroquinolones, right? Great job. All right. Your nurse practitioner is prescribing medication for a 77-year-old with GERD. Which of the following medications would be your first line for this patient? So again, this is talking about tailoring patient care. This is talking about some of those caveats that, those outliers. So what do you all think? Y'all can put it in the chats. I don't think the boards are going to confuse you this much, but if y'all can do this question, y'all can do anything. All right, very good. That's right. Proton pump inhibitors are going to be the best choice for your short course of aggressive treatment for your geriatric patients, right, who have a high risk of complications. Of course, high doses and long-term use can increase risk of fractures and malabsorption. So if they can't be coming off of that PPI within that 12-week time frame, this patient needs to go and have a risk versus benefits and probably an endoscopy talk with GI. So absolutely. All right, what about this one? Which of the following meds for depression medication is contraindicated in a patient with comorbid epilepsy? So what do you think about this one? So do y'all remember which one you can't take with epilepsy? Give you just a minute. This is a little bit harder of a question. We did not specifically talk about this today, but it's something that I want you to know here so that you get it right on your test and most importantly in practice. Give you just another minute to put it in the chats. What you're thinking. Absolutely. So this is Wellbutrin. Excuse me. That one is not one that we talked about today, but it can lower the seizure threshold and it's contraindicated in patients with a seizure disorder. Okay, so again, just some practice questions for you that I just kind of picked at random. But you can go get more practice questions at the Q Bank and for free for 7 days. So I will leave this up for y'all for just another minute. Heva and I are sticking around for questions if you have any questions over the next minute or so. And then we're going to turn it off for today. But I will see several of you, I'm sure, coming up in the live review. And I have another topic in the month of November. Check that out on social media when that's going to be. I know Heva has some talks coming up, Morgan, Rachel. So, just come and interact with us. We love to see all of you and, help you in any way that we can. So, all right. Do we have any other questions in the chat, Heba, that we need to address? You've been watching the chats for me while I've been
I was gonna say
yapping.
everyone's been really engaged today and the questions have been looking great and we're looking good so far. And remember, if you guys want to see the recording of this video, you can join our Facebook group. I put the link in the chat and you'll get the recording of this lecture as well as all our past lectures that we've done. So don't miss out on all that free content.
All right, guys. Okay. Well, hey, it is really good to see everybody today, and we will plan to see you all soon. I think as soon as tomorrow, some of y'all. So we'll see you soon. Thanks, Eva.